Hi, and good afternoon, everyone. Welcome to our guest, new and old, to MRF HIV STI ECHO. This is our 83rd session. And today we welcome Dr. Chris Behrens from the University of Washington, who is an infectious disease specialist and also a global health specialist. And we are going to discuss an update to pre-exposure prophylaxis. There's been a lot of conversation about both oral PrEP and other forms of PrEP and implementation and all the good data and good science that runs behind it. So I won't preempt Dr. Behrens' discussion. I'll just turn over to you, Dr. Behrens, and thank you again for giving us the benefit of your time and expertise.
Great. Should I go ahead and start then?
Yes, go ahead.
Okay. Thank you very much for inviting me to do this. And I just want to acknowledge that some of the slides I was given by Dr. Jared Baton, who was actually one of the lead researchers in pre-exposure prophylaxis for many years. So without further ado, hopefully this, oh, I need to share, sorry. All right. Okay, hopefully you're seeing that properly now. I want to do the usual acknowledgement of our sponsors for these events. I have no relevant financial disclosures. Our learning objectives, hopefully by the end of this, you'll be able to summarize evidence supporting PrEP as an effective HIV prevention strategy, review management of some special situations for PrEP, describe the baseline and follow-up monitoring, summarize WHO guidelines regarding PrEP, and explore this issue of same-day PrEP initiation. And I'm hoping to leave some time to, basically explore whatever other aspects of PrEP you might be interested in discussing. So the basic concept of pre-exposure prophylaxis, and this is the sort of daily dosing approach, is that one takes a medication every day. In this case, Truvada, which is a combination of tenofovir and FTC. And by taking that medication every day, one hopefully prevents infection with HIV, despite exposure to that agent. And this whole idea is not entirely new. We've been using it for example, malaria prophylaxis, where we use a malaria treatment agent, take it every day, and it can very meaningfully reduce the incidence of malaria. So that's the daily approach. The way it works, sort of logistically or mechanically, is that the medications in PrEP, shown as the yellow and orange diamonds there, penetrate into the mucosal surface in the genital region in this case. They float around in that region. They get picked up by the target cells for HIV, including macrophages, dendritic cells, CD4 cells. And that way, if there is an exposure with HIV, shown here as those various colored spheres or globules, then the drug that is already on board in the cell will prevent replication and thereby prevent infection. Not to go through all the clinical trials data, but I'd like to just try and summarize that we have a lot of data now from very high quality randomized controlled trials showing that this works. And we have that evidence for different at-risk target groups. So, for example, in male and female heterosexual groups, we have significant evidence of efficacy from the Partners PrEP and the TDF2 trials. These were performed largely in sub-Saharan Africa. And you can see there the HIV protection that was shown in the randomized trial, 75%, 62%. But importantly, when you actually account for adherence, you actually see significantly higher levels of protection. So think of this as the intention to treat analysis versus on treatment analysis. I think very relevant to our discussion is that it has been clearly shown to work in men who have sex with men and transgender females. The most significant study in this population was the PrEP study. Now, the protection seen in that study was not terribly high overall by intention to treat analysis, just around 44%. However, adherence was not the greatest either in that study. And again, when you look at a sort of on-treatment analysis, really looking at protection levels among individuals who were actually taking it, as evidenced by being able to show that there was tenofovir in the bloodstream, the efficacy was more like 92%, much, much higher. Interestingly, we also have evidence that this approach works in injection drug users with a significantly high protection level as well, a study done in Thailand. And I should point out that there were some negative trials of PrEP, most significantly the PrEP and the VOICE studies that were done among female heterosexual women in sub-Saharan Africa at high risk for becoming HIV infected. There was no benefit seen, but on a sort of post-hoc analysis, they discovered that adherence was extremely low, owing to some unfortunate sort of misinformation and misperceptions about these medications. So I think the bottom line here is the PrEP works, and when adherence is good, HIV protection is consistent and quite high, even among different population groups. In fact, this is another slide that was follow-up data from the PrEP study, and if adherence is very good, 4 doses per week, efficacy 96 to 100%, 7 doses per week, individuals taking it every single day as instructed, 99 to 100% effectiveness. So I think we can count on this idea of PrEP to work kind of the same way antiretrovirals do in treating chronic HIV infection. If you can take it every day, it's very, very effective. Now, this idea of taking it every single day is not the only approach out there. There is another approach called event-driven pre-exposure prophylaxis, or ED PrEP. This is also known as on-demand PrEP, or 2+1+1 approach. So confusingly, we give it 3 different names, but I think it'll become clear as I review what we're talking about. The idea here is that you don't necessarily have to be taking this medication, Truvada, every single day. You take it as needed. However, you have to take it before the sexual exposure. And the way this approach works, 2 tablets of the Truvada, or TDF-FTC, are taken in a window anywhere between 2 to 24 hours before sexual intercourse. And this was only studied among 4 sexual encounters, okay? And then there's the exposure event as shown. And then one takes another tablet 24 hours later, and then another tablet 48 hours later. So 2 tablets prior to the sexual encounter, another tablet 24 hours later, and another tablet 24 hours after that. And the important thing to note, though, is if there are ongoing HIV exposures before this sequence is completed, well, then you're going to continue taking once daily tablets of the TDF-FTC until there are no more exposures and 48 hours has elapsed. So I think that that makes sense as a concept. This approach was studied very well in what's called the IPRGAY study, performed in France and Canada. It was a high-quality, randomized controlled trial in which men or transgender women who have sex with men were randomized either placebo or the active drug Truvada and followed over time. They had 400 individuals enrolled in this study. And what they found was that this approach was highly effective, and the risk of becoming infected was reduced by about 86% among those individuals who were randomized to the active drug arm, which is roughly the level of protection that was seen in the other prevention trials in which Truvada was taken every single day. So I think this is a very encouraging result, suggesting that it's about as effective as daily PrEP. There was a sort of a real world study of this approach as well, because it's one thing to see how well things work in randomized trials, but it's also very helpful to see how does it play out in the real world, so to speak. And this was a study performed in the Paris region, in which over 3,000 individuals at high risk for HIV infection were offered the option of either taking daily TDF-FTC or doing the on-demand approach. They weren't, randomized, and this was open label. And they followed them over the course of 3 years to see what the rates of HIV infection would be. And they're hoping to see overall reduction in new HIV diagnoses among men who have sex with men in the Paris region. And what they found was very encouraging. In other words, they found that there were actually only 2 infections that occurred over the course of those 3 years. They estimated that among participants, 143 HIV infections were averted. The 2 infections did occur in the on-demand PrEP group, but compared to 0 in the daily. But this was not a statistically significant difference. And in fact, if you look at the 2 cases where the infection occurred, well, it turned out that both of those individuals had actually stopped taking the medication and were not adherent to it, and then had condomless sex. So really not very surprising that they might have contracted HIV in that scenario. So, but I think that does underscore the fact that we offer PrEP as part of combination prevention, right? We see very high efficacy rates with high adherence, but nevertheless, we should always be emphasizing other ways of preventing HIV. We should also be emphasizing the fact that this, PrEP, whether it's taken daily or whether we use the on-demand approach, offers no protection whatsoever against other common sexually transmitted infections. So, condoms should be offered. Sex workers need to be thinking about and empowered to insist on condoms, for example. Those who inject drugs, for example, should have access to clean needles, etc. So just to emphasize, this is a very important tool in our toolbox for preventing HIV, but it's not the only one, and it should always be offered in the context of supporting other ways as well. All right, now let's talk a little bit about the safety of PrEP, because there have been some updates around this issue as well. There was a systematic review and meta-analysis of the risk of adverse events associated with TDF-FTC PrEP in 13 randomized trials. And what it found was very encouraging. PrEP looked very safe. There were no significant differences in the rates of adverse events when you compare the individuals in these randomized trials who received PrEP versus those who received placebo. And this extends to renal and bone issues. And these are important because we know from individuals taking TDF for long-term HIV treatment that we occasionally do see bone mineralization issues, and we do occasionally see nephrotoxicity. So these were legitimate concerns going into these studies and trials. By putting people on PrEP, are we potentially going to risk their bone health or their kidney health? So far, it looks like that's really not a meaningful problem. The renal health problem stems from the fact that tenofovir has this effect on the proximal tubule in the kidney. And it can accumulate in the mitochondria there, causing dysfunction in that part of the nephron unit. And severe cases can look like something called the Fanconi syndrome and can actually be quite significant. This is why individuals who are on tenofovir are required to have renal function monitoring on a regular basis. To make sure we don't miss this problem. Fortunately, it's almost always reversible. But in the context of PrEP, well, how big a consideration is this? The meta-analysis of the randomized trials, as I showed before, suggests that it's really not an issue. But we have some other data as well. There was a systematic review and meta-analysis of global program data that led to some updated guidelines by the World Health Organization. What they found in this review was that less than 1% of individuals who were screened before starting oral PrEP had abnormal creatinine clearance levels. So less than 1% of individuals starting PrEP even had any indication of renal dysfunction at baseline. And that's not too surprising because I think, the main target group for this are, for PrEP, at least in the United States, has been men who have sex with men, who tend to be younger and have healthier kidneys. Less than 3% of oral PrEP users experienced a decline in creatinine clearance to less than 60 milliliters per minute. So again, very low numbers actually saw any decrease in their creatinine clearance while on PrEP. Less than 1% of oral PrEP users younger than 30 experience abnormal creatinine clearance. So vanishingly small problem among those less than 30 years of age. It seems like this problem, when it does occur, which is not often, tends to occur among older individuals, especially those over 50 years of age, with a baseline creatinine clearance less than 90, and with kidney-related comorbidities, other illnesses that can affect kidney function, such as diabetes or hypertension. Those are the individuals who I think we need to be thinking a little bit more about monitoring creatinine clearance and kidney function while they are taking PrEP. So the WHO sort of updated its guidance less than 2 years ago to include the following statements. Some programs may opt to screen for creatinine clearance for all oral PrEP users. However, since creatinine elevation is so rare among individuals less than 30 with no kidney-related comorbidities, creatinine screening may be considered optional in this group. So this is a major change. Previously, WHO guidelines and also all United States guidelines had said, yes, you have to monitor creatinine clearance and you have to screen before starting. WHO is saying, look, if they're young and they're healthy and no kidney-related illnesses, you don't need to do that. To simplify the delivery and cost of PrEP, all individuals 30 years and older, and those younger than 30 who do have comorbidities that might affect kidney function, can be screened for serum creatinine once within 1 to 3 months after oral PrEP initiation. So this too is a major change. It says you don't even need to check a baseline necessarily. You just need to check within 1 to 3 months after starting PrEP. And furthermore, if it's normal, you don't necessarily even need to continue monitoring. More frequent screening than once is only suggested for individuals of any age with a history of comorbidities that affect the kidneys, such as diabetes or hypertension, those 50 years or older, and those who have had a previous creatinine clearance result less than 90. So for these users of PrEP, a further test after baseline screening and every 6 to 12 months thereafter can be considered. So I think what I wanted to highlight with this is that we're really sort of, based on very strong data, really pulling back on the need for monitoring kidney function. And that's really going to simplify delivery of PrEP in our programs, as we'll talk about in a little bit. Now, when screening is conducted, anyone with a creatinine clearance greater than 60 can safely be prescribed TDF containing oral PrEP. Waiting for the results should not delay starting the oral PrEP, and this is really important. You don't need to do the test, wait for the results, and then try to start the individual on PrEP. You can simply prescribe the PrEP, have them come back, and then review the results. You're not going to do significant harm by prescribing tenofovir for PrEP and then discovering, oh, their creatinine clearance, is relatively low, and maybe they shouldn't be on this medication. It's fine. You can simply stop it when they come back for their follow-up visit. Abnormal creatinine clearance, moreover, should be repeated on a separate day before stopping PrEP. Creatinine clearance, is going to vary a fair amount from day to day. Because the typical way we measure creatinine clearance is kind of a rough, I would call it a rough and dirty way. We measure the serum creatinine. This roughly correlates with kidney function, but it can be affected, for example, by just a little bit of dehydration. So if I have a patient who has a low creatinine clearance as suggested by an elevated serum creatinine, I'm going to ask them, before I do anything, come back, make sure you're well hydrated. We're going to repeat that, and we're going to double check before we make any changes. If there are changes in creatinine clearance that are due to the tenofovir, usually returns to normal after stopping the PrEP. And one can actually restart the PrEP if the creatinine clearance rebounds to a healthy level, right? So that's another significant change from the 2017 WHO guidelines. Now, if it does not return to normal levels after stopping PrEP, it's worth looking at other causes of renal insufficiency or chronic kidney disease, especially if some of these other features are present. An elevation more than 1.5 times the upper limit of normal. If they don't return to normal after stopping the PrEP, if they become progressively worse over time, right? Because there's so many things that can affect renal function, and we don't want to be too hasty in blaming it on the tenofovir. All right, let's talk a little bit about PrEP implementation and the nuts and bolts of this. The WHO has put together a very nice set of modules all about implementing PrEP. And these various modules focus on different sort of target groups and audiences for those who need to be reading and following this. So module 1 is the clinical one. This is for the clinicians, physicians, nurses, clinical officers, really providing the nuts and bolts of how to do this. Other modules focus on community educators and advocates, counselors, political leaders, pharmacists, regulatory officials, site planners, people who manage clinics and hospitals. So I think it's marvelous, and including a module for PrEP users, right? Something that really targets the patient. So I think it's marvelous that they came up with this very nice comprehensive package that's broken out according to target groups. So I really encourage accessing this on the WHO website if you want to be expanding your PrEP programs and using it or with existing programs just to better reach the individuals who are key stakeholders in this. So with that, let's take a look at some of what's in the clinical module, for example. And this is, it's almost like a card. You could clip it out, front and back, and keep it in your pocket, because it's just a very quick reminder of the basics of PrEP. So indications for PrEP, based on history: individuals who are HIV negative, that's key, of course, and has a sexual partner with HIV who is not virologically suppressed or sexually active in a high HIV incidence prevalence population, and has any of the following: vaginal or anal sexual intercourse without condoms with more than one partner, or a sexual partner with one or more HIV risk factors, or a history of sexually transmitted infection, or use of post-exposure prophylaxis at some time in the past, or requesting PrEP. And I think that last point is important. We really, I almost never decline to prescribe PrEP, right? If somebody comes in and is asking for it, I will go through and explain what PrEP is, what it's for, how it works. And if at the end of it, the individual in front of me wants to take the PrEP, I'm going to prescribe it. I'm not going to ask, for proof that they have these certain risk factors or not. They may not want to talk about that. They may be reluctant to talk about their, their sexual behaviors, or maybe that they're using injection drugs. So I certainly don't want to miss an opportunity to prescribe PrEP just because I'm not able to elicit the key risk factors. So I think that's why that last bullet point there about requesting PrEP is so important. Obviously, you want to make sure they understand what this is for, but if the individual does grasp that, then again, I say go ahead and offer the PrEP. There are, of course, contraindications. You never prescribe this to someone with HIV infection. If the creatinine clearance is estimated to be less than 60, we're not going to prescribe this, although, again, you're going to want to confirm that. And you don't necessarily, if you have no evidence of a low creatinine clearance at the time you see this individual, that should not stop you either, as we'll talk about in a little bit. It's okay to go ahead and prescribe it. If this is an individual over 30 or has risk factors, well, then you will check, but that's not going to stop you from prescribing it. You can always stop it at the next visit. Now, this next point is important. If this individual has any signs or symptoms of acute HIV infection or a probable recent exposure to HIV, this is not the right time to start PrEP. If the former, if signs, symptoms of acute HIV infection, well, you're going to evaluate for that, and that's its own sort of algorithm of, doing the antibody testing. Doing a viral load test if you can, and if you think the symptoms or signs really match with acute HIV, and then having them come back. Similarly, if there's been a probable recent exposure to HIV, well, then we're looking at post-exposure prophylaxis in that scenario, not pre-exposure prophylaxis. And so for those individuals, a 28-day or 4-week course post-exposure prophylaxis is the most appropriate thing to do at that time. Then have them come back. and potentially transition directly to pre-exposure prophylaxis. I have done this many times with my patients. It's common and safe. Once they finish the course of post-exposure prophylaxis with 3 drugs, well, they simply drop the 3rd drug and then continue with the TDF-FTC for PrEP. And then, of course, allergy or contraindication medicine in the PrEP regimen, that's going to contraindicate it. It's very simple prescription. Truvada is a co-formulation of tenofovir, diproxyl fumarate, and FTC or emtricitabine. I should note that it's also perfectly reasonable if your co-formulation locally is tenofovir plus 3TC or lamivudine. That is also fine to prescribe. It's just as effective for PrEP as the Truvada formulation. And then, of course, the counseling about how to take this and how messages to try and promote adherence, as well as the other combination prevention approaches that we mentioned, because, of course, you need to educate these individuals. This is nothing to prevent getting pregnant, nor does it do anything to prevent infection with other sexually transmitted diseases. There are some key messages that should be conveyed about effectiveness, namely that it's very effective when used as prescribed, again, but doesn't prevent pregnancy or STDs. Side effects can occur. In the meta-analysis that was performed and reviewed, these side effects were actually no more common than was seen in placebo group, but nevertheless, nausea, abdominal cramps, headache, these are usually mild and they typically go away over the course of the first month of taking the PrEP. The creatinine elevation, as I mentioned, is rare and depends upon your risk group and is almost always reversible once you stop it. The bone mineral density, some was seen, but again, it was no different from those randomized to placebo. So it's not really clear that this is something related to the medication or just happens, is happening with age or something else in these groups. The initial tests that are generally recommended, well, HIV testing is critical, of course. Creatinine, as we went over, is indicated for some groups. You want to screen for active hepatitis B infection. And the reason for this is because, Truvada or TDF plus FTC, similarly TDF plus 3TC, these are medications that are not only active against HIV, but are also active against hepatitis B. And so if your patient actually has chronic hepatitis B, well, then you're putting on treatment. You're putting that individual on treatment for their hepatitis B, which is often a good thing, right? However, what we do know is that sometimes when individuals who have chronic hepatitis B and are on treatment, if those individuals stop their treatment, sometimes the hepatitis B will flare and they can get ill from this flare of hepatitis B with inflammation of the liver. And of course, PrEP is not something that's necessarily meant to be taken, lifelong, the way hepatitis B treatment might be. It's intended as something to be used for periods of time when an individual is at risk, but then if that risk goes away, then they could stop taking it. So we check for hepatitis B infection at baseline because we want to know if we're starting treatment for someone who has chronic hepatitis B, and if so, well, we may want to just keep them on these medications to treat their hepatitis B. And of course, the management of hepatitis B is a whole nother discussion, but fortunately, this overlap means that it's not that difficult to treat chronic hepatitis B in individuals who have HIV or in individuals who want to be on PrEP. We are definitely going to want to screen for other STDs. I mean, if this individual is at risk for HIV, they're at risk for all the other STDs as well. In men who have sex with men, hepatitis C is sexually transmitted, so we're going to screen for that as well. Roughly every 3 months, HIV testing, probably checking for other STIs, that's going to be indicated as well. Assess the PrEP indications, assess adherence, see what other issues may be warranted. And every 6 months, creatinine may or may not be indicated to check, again, based on age and risk factors, as we previously discussed. And then, of course, the special situations. If they've been exposed to HIV in the past 72 hours, you're going to use post-exposure prophylaxis, then transition to PrEP. If they have any signs or symptoms of acute HIV, you're not going to start PrEP at that time. You're going to work up for acute HIV. You're going to wait at least a month, retest at some point. If it is in fact acute HIV, they definitely should be testing HIV positive a month later, and then you can sort of safely proceed. In women who are pregnant or breastfeeding, PrEP can be offered and should be continued in women who become pregnant or start breastfeeding while on PrEP. We know these medications appear to be quite safe, both in pregnancy and breastfeeding. If your hepatitis B screening discovers, establishes that they do not have chronic hepatitis B, really they should be vaccinated because hepatitis B is sexually transmissible, and so it should be thought of as another STD in this case. If the testing shows that they actually have chronic hepatitis B, well, if they haven't started PrEP yet, it's worth thinking a little bit about whether they should be on chronic hepatitis B treatment or not, and then think about this flare if the PrEP is stopped. So that's a situation where you might want to consult with an infectious disease or a liver specialist to figure out the exact best way to proceed. All right, so the WHO put out what I think is a pretty nice algorithm for considering how to offer these two kinds of PrEP that we know are effective, the daily dosing versus event-driven. Really, it comes down to patient choice, right? Assuming this is an individual who is appropriate candidate for PrEP. I think it's appropriate to present these two options: event-driven dosing, if this is for individuals for whom sexual intercourse is, well, predictable in a certain sense, and especially if their sexual encounters and exposures are relatively infrequent. These are the individuals for whom it makes the most sense. Conversely, if it's really not predictable or the sexual exposures are frequent, it makes a lot more sense just to do daily dosing. And note that it's perfectly fine to switch between these two approaches. Circumstances change, and so people may switch from daily dosing to event-driven, might go off PrEP entirely, or vice versa. Okay, so so how do we manage these individuals on the first visit? These are the tests that are warranted. We've covered much of these already, but it's a nice table from the WHO guidelines, and I've sort of replaced the relevant text with highlighted text to reflect the 2021 updates about serum creatinine testing. I think we've covered this, but I wanted to include this slide because it's just a nice summary to keep on hand what to do, what to test for at the first visit. And then similarly, this is what's done at follow-up visits. The follow-up visits, I generally have people come back at least every 3 months. And I think it's important to do that for testing for HIV and for other STDs. We do see, at least in the United States, a relatively high incidence of other sexually transmitted infections among MSM who are on pre-exposure prophylaxis. So I think if for no other reason, having them come in every 3 months really offers the best opportunity to screen for and promptly treat sexually transmitted individuals. If they're positive, they can be counseled to notify their partners so that their partners can get treated as well. In some circumstances, expedited partner therapy might be indicated, in which you don't even necessarily have to bring in the partner, but they are automatically prescribed treatment for whatever STD has been diagnosed. Mechanistically, I typically prescribe just no more than 3 months of the PrEP at a time, and say you have to see me again in order to get refills. All right. Now, same-day PrEP initiation. I want to spend just a few minutes on this because I think it's a worthy thing to approach to consider. The rationale here is that we know, I hope I've shown you and convinced you how effective PrEP is, but it is definitely underutilized, at least here in the United States. Of the estimated 1.2 million people here in the United States who for whom PrEP would be indicated, it's estimated that that less than 1 in 5 are actually getting it. So we're really underusing this very valuable intervention. If, however, we could prescribe PrEP on the exact same day, at the same time as we see individuals who want to start PrEP, we could probably make a significant impact in expanding access to it. And I feel like I'm preaching to the choir here, but I think we all understand that when referrals and follow-up visits have to happen, all too often we miss an opportunity because those follow-up visits don't happen or the referrals don't occur due to various reasons. So there are some, I think, reasonable concerns about this concept of same-day PrEP. Safety, missing HIV individuals, HIV positive individuals, continuing PrEP, but I think there are quite a bit of data and evidence to sort of argue against these safety concerns. We've talked about the creatinine issue. It turns out to be much less of a problem than was initially feared or concerned about with PrEP. For many individuals, it's really not even necessary to check baseline creatinine, as I mentioned. But if you do, well, if you could have point-of-care creatinine testing, that would be ideal. Now, granted, a lot of patients don't do that. However, it is okay to do the blood draw that will measure the serum creatinine, go ahead and prescribe the PrEP, and arrange for follow-up, within a month, say. And you're just not going to do any significant harm to the kidneys by prescribing tenofovir or Truvada in this setting. Okay, there was a study done of same-day PrEP prescription at sexual health clinics in New York City. It found only 0.1%, so about 1 in 1,000 individuals who were immediately prescribed PrEP actually had a real contraindication for starting PrEP. So really not much of a problem there. What about missing, people with active HIV infection? Well, ideally we could do same-day testing of these individuals and rule out active HIV infection at the time. But I guess the approach I often take, if I don't have same-day HIV testing available, is I will do the HIV test, draw the blood sample. I will prescribe the Truvada, the pre-exposure prophylaxis, and I'll tell them, look, you can take this prescription home, but don't start it until I get back to you with the results. And I'll call you with those results. I'm not going to, insist you come back for a follow-up visit. And that way, they're ready to go. They just need the green light from that HIV test result, which they will get in a few days. And I think that's a sensible way to proceed. And then in terms of like ongoing PrEP, well, you know, one concern is, well, if we're starting PrEP on the same day, I mean, are we sure they really want to do it? You know, is this just a transient thought of theirs? We really haven't seen that as being an issue. And if they decide not to take it in the end, well, that's okay too, right? This is something that's meant to be taken, you know, intermittently, I would say, as on a as needed basis, depending on their life circumstances. There have been some real world trials of this here in the United States. I'll just highlight a couple in Colorado and Missouri. In Denver, Colorado, there's a pilot study done with 100 patients started on same-day PrEP in their STD clinic. 78% completed a 1-month follow-up visit for continuity. Over half completed 2 follow-up visits. Nobody stopped PrEP because of concerning laboratory results. So again, they had HIV screening at the point of care, but that was the only test that they had available, you know, at the time. And all the other tests were, you know, they were just ordered, and it worked. You know, that approach seemed to be just fine. St. Louis, they started prescribing same-day PrEP really several years ago. And they solicited feedback from the PrEP users about, you know, how best to do that and where the bottlenecks were. And I think this is sort of, you know, instructive that nobody's going to understand the, you know, the barriers and bottlenecks with PrEP better than the people to whom we're prescribing it. They had a rapid HIV testing at the time. But similarly to Denver, they would collect the labs on that day and then get results back within 24 hours. They would give the patients a prescription at the time, schedule follow-up in a month, and then 3 months thereafter. And they had very, very positive results from this. 97% of the individuals who were given prescription that same day actually started it, right? And 78% continued PrEP for at least 3 months, at least based on refill data and self-report. And furthermore, they were able to show that same-day PrEP prescribing resulted in less delay in receiving the prescription and faster initiation after prescribing than the past usual care. Very encouraging results in terms of nobody had to stop their PrEP because of baseline abnormalities. Nobody had an HIV positive test result during the first 90 days of follow-up. So they weren't missing any undiagnosed HIV, and nobody had to stop their PrEP. So I think I'm looking at the time, and I want to really allow time to have a conversation as a group about, you know, where do things stand in Trinidad with pre-exposure prophylaxis, and you know, there's so many different issues that can be explored with pre-exposure prophylaxis. I want to allow time to, you know, hear your questions and have some rich discussion. So I think I'm going to stop there and open up for discussion.
Okay, thank you, Dr. Behrens, for that presentation, enlightening as always. As you would have opened the door and opened the floor to conversation about some of the issues. I see Dr. Sieber, Dr. Edmonds are here, as well as Cyrus and Dion from a HIV perspective and from somebody who works in the ministry. I wonder if we could first have a conversation, both from Dr. Edmonds and Dr. Sieber, with respect to where we are, if there's been any movement in respect to the ministry's attitude with respect to pre-exposure prophylaxis, because it's not available in Trinidad right now, at least not from the Ministry of Health. There was a pilot project of trainer exercise in which I participated. Presumably, hopefully there's a pilot project later on. But I'll ask anyone who's here to have to fill us in on that. Has there been any movement? And while the responses are coming in, Dr. Evans, go ahead. I see if I'm muted.
think Dr. Sieber is the best person to ask about that. I know PAHO has been in discussions with the ministry, but I don't think there's any policy as yet as it relates to PrEP. But again, Dr. Sieber, you can answer that better than me.
Hi, afternoon, everyone. So there's not been an update in terms of an approval for this, as I'm aware. So we've done some of the other parts. So for example, where Dr. Behrens would have been speaking related to the process of implementation, we have begun to assess in terms of cost of implementation, possible places to support implementation, but we haven't had a shift in policy. So until there is a shift in policy, the MOH would not be able to implement. There is anecdotal evidence that people are accessing PrEP in other countries in the region. And some, I think, are also buying things online. But there's not been a shift at this particular point in time in terms of a green light to proceed. Over.
And do we know what that runway looked like in terms of what the ministry or PAHO or anyone else is thinking of in terms of what needs to be in place before that green light is given? Is there still a reluctance to simply the concept behind PrEP? Are you still worried about, risk compensation? What's the...
I don't think it's a so from where I sit, I don't think it's an issue with respect to I think the conversation around PrEP is the same conversation around the health and family life education. It's one of those areas within the response that we have been getting a lot of pushback for, especially in terms of the concerns with respect to how, for example, the faith-based groups will interpret how this is actioned or the actioning of this intervention. And so similar, so like with HFLE, we've had a lot more conversation with from Dr. Behrens. HFLE is health and family life education. So we've been having some challenges with that based on how that is perceived in terms of young people and that kind of thing. I'm seeing also another question in the chat, but when we did an assessment with respect to PrEP, we looked at the use of tenofovir, given that Truvada is in the system. So that is the intervention we looked at, as well as we looked at the use of the vaginal ring in terms of the opportunity to use that for women and the cost. So those were the things that we looked at in the first instance, but I think we have to figure out the other parts, because there are things in our system that affect implementation of things that require a significant amount of engagement before some of those things happen. So there's that. I'm just noting in terms of the injectable, the issue of the injectable drugs, with respect to a lot of the new antiretroviral drugs, we do have the challenge of the spin-off in terms of the cost of some of the drugs, because we are classified as a high-income country. And where we are classified as high-income country, we are having challenges to access some of the drugs in terms of the volumes that we would have to. So in terms of the switch, there's that ongoing discussion in terms of how some of the newer ARVs that we may want to access in the future would need to be accessed because of the IPO, the patents and that type of thing that we will be experiencing.
Just to have a quick run through. So both Dr. Edwards and Kwesi Gill were referencing injectable PrEP. I know that can be a whole separate discussion, but I wonder if this is something Dr. Behrens, you can just touch on in terms of injectable PrEP and how that's been changing the landscape of PrEP and PrEP access and that sort of thing in the US, or some of the early outcomes are?
Sure. So I do have a few slides I can go through real briefly. We're talking about, for injectable PrEP, cabotegravir, a long-acting. Cabotegravir is one of the integrase inhibitors, and sort of like dolutegravir, for example. And there is a long-acting injectable formulation that has a very long half-life in the bloodstream when it's injected. It's worth noting it has a relatively low barrier to resistance, unlike dolutegravir, for example. But there was this very high quality HIV prevention trials network study, 083, that looked at, well, can we use just this one drug as an injectable, to prevent HIV infection. And it was kind of a complicated study because they, to really have a proper control group, right? They're comparing it against oral TDF. So people in each arm had to be getting injections and had to be taking pills. And they had to be doing this for actually a fairly prolonged period of time in order to be able to assess any difference in incident HIV infections. This was done among cisgender MSM and transgender women at high risk for HIV, by the way. So, in just sort of one of those at-risk groups. That's another sort of picture of what this looked like. Pretty long trial, and there was this lead-in period of having to take oral cabotegravir for 5 weeks to make sure it was tolerated as well. So, which speaks a little bit to, this is kind of complicated, but in the end, it did turn out to be quite effective. Now, the study was designed to be a non-inferiority. They were really only trying to prove that cabotegravir was, not inferior to Truvada, TDF FTC, and they definitely showed it was not inferior. In fact, the evidence suggests that it may actually be superior to Truvada in this study. So that is essentially what has given the green light to doing it, and we are doing it in the United States, but it is expensive, and it is a little, you have to do this cabotegravir lead-in. You have to make sure there's no resistance, at baseline to the integrase inhibitor class, and so I see this as something to definitely keep an eye on. But I guess I would say get the oral Truvada going first, and then I think it's more important to make that program work, and then you can start to look at this. It is worth noting, though, that a lot of groups prefer the injectable. It's a lot of people just prefer to take an injection every 2 months or so rather than taking a pill every day. And these are some follow-up studies that just showed that the main reason it did better was, well, adherence. Probably that's a big reason why people like it. But there's also some things we still don't quite know, and so that's another reason I think to keep an eye on this. But I would think the focus would be on getting the oral PrEP programs up and running.
Okay, thanks, Dr. Behrens. Just gonna quickly run through 2 other comments from Sarah's. Persons accessing PrEP privately, but the risk associated with not being followed up by a healthcare provider. I think you all agree with that. If they're not getting STI screens or regular HIV tests, they may be just taking PrEP, even though they already have been positive at some point in time. And second, from Dr. Seabrook, persons who are accessing PrEP privately can proactively visit STI clinic with the PrEP providers for follow-up to address the additional supports as well. And again, that's always another option. So again, if you feel like we just, got a taste of a 5-course meal, but again, there's always so much discussion on this topic, and we hope at some point in time in the very near future we can announce the beginning of a national PrEP program, because I think the evidence and data is in. We know PrEP is an effective intervention in the context of combination of prevention for HIV and STIs. And again, thank you, Dr. Behrens, for your comprehensive review. And I hope we just keep the conversation going. I hope we can continue advocacy around this important point. So I just want to mind the time, but just a smidgen over 3 p.m. So again, thanks those of you for participating. Thanks for your comments. And I wish that we can continue this going offline. That's it for our 83rd session of HIV STI ECHO. Again, thanks all of you. Thanks, Dr. Behrens. And we shall be catching up with you later. We shall have another session with Dr. Behrens in 2 weeks' time, again on a Friday. As usual, we'll be uploading the video to YouTube for those of you who want to recap or to recommend the session for those who weren't able to make it. Thanks, everyone. Take care. Have a great weekend.
All right. Thanks, everyone.
Bye, everyone. Thank you.
Thanks, everyone. Bye.
Thanks for coming. Yeah, usually Dr. Behrens will send us the slides. So let's send an email reminding him. All right. Take care. Signing off.